Hi, I'm Linda McLean, and I'm coming to you from the Live Lounge at ICS 2024 in Madrid. I'm here with Marylène Charette and with Heidi Moossdorff, who were both presenting in the Physiotherapy Forum this morning. So welcome to you both.
Thank you. Welcome.
I wanted to start by just asking you to tell us briefly, for people who were not at the Physiotherapy Forum, what your presentations were about. So Marylène, I'll start with you.
Yes, of course. So I was giving a presentation on the challenges of doing informed care in primary care, and looking at the challenges and barriers and facilitators to apply recommendations from high quality guidelines in clinical practice.
Okay. Thank you. And I'll just ask you a few questions about that that might be of interest. So my recollection is that you discussed why and how, in what ways primary care providers were not adhering to guidelines for urinary incontinence in women. Did you find anything that was surprising or of particular interest?
Yes, not always super surprising, but shocking as well. So having male physician not necessarily being comfortable doing pelvic exam, and for them to give their female patient to female colleagues or refer them to female healthcare professionals that can assess and treat UI. So I feel like it's a slippery slope, and that male physician not necessarily being able to assess properly for incontinence, that it's not necessarily sustainable in the long term, that having only female treating and assessing female, so having to think about what would be good intervention to try to address that. So that was shocking in terms of findings. Yes, absolutely.
Mm-hmm. And did you find as well, I know that your research is being done in Canada, and I think there are similar problems across the world in terms of access to primary care providers, and particularly since the pandemic, we seem to have been witnessing more provider fatigue and burnout. Did that play into the care being provided to women?
Of course, and they highlighted that issue as well. They don't really know how or the extent they need to take a patient, assess and treat it before doing a referral. They are really fatigued, and they're treating multiple conditions. Patients come in with a laundry list, not necessarily having incontinence being their main concerns. They're like fatigue and overwhelming plays a big part in physician not doing or following recommendation. That's for sure. I'm pretty sure that it's similar in other provinces, other countries as well, and that we need to find a solution to bridge that gap, or to make sure that that it's being addressed. And I think we don't have the specific answers for that, but more research needs to be done in that area.
I have a question, because in my PhD it was with regard to urinary continence in the peripartum period. We did qualitative research, and the midwives and the physicians, they said, well, we're just running out of time. We don't have time to do these examinations. And was that a problem in your...
Yes, it was. The majority of them only have like 15-20 minutes to assess and treat patient and multiple conditions at once. But it doesn't take away for them to ask the patient to come back, or to open their schedule to see them on multiple occasions and assess and treat on multiple occasions. So you don't have to do everything in one visit, and I felt like they feel pressure to do everything at once.
Would it be a solution that you work together with a pelvic physical therapist, and that they do the exam and
yes,
together with the physician?
A big concern, though, it's accessibility to pelvic health physiotherapists. So it's good for maybe like urban cities, urban region where they have really a high ratio of pelvic physiotherapists to the population, but it's not the case in rural settings. So it's not necessarily equitable, and it's not necessarily feasible, and like it's not sustainable to do this kind of thing. I feel like that's my own opinion, but yes, it has been mentioned and has been suggested in the literature that maybe physiotherapists working in clinics could help mitigate and assess and deliver appropriate care to these women.
Yeah.
Yeah. Certainly when time becomes an issue, as physiotherapists, particularly in pelvic health, we allocate an adequate amount of time to do a thorough examination, which is rare at least in our Canadian healthcare system, although I believe that is consistent across the globe. And so having that time available is super important when there are so many factors involved in taking a detailed history, doing a pelvic exam, sorting out what the patient goals and priorities are, and what may be the best treatment pathway for them.
And we're putting a lot of pressure on the primary healthcare system. Like, they need to do a lot. Like, it's not easy to do their job. I wouldn't like to be doing what they're doing. So it's having a solution that maybe if we go more preventive and we're trying to for women to advocate for their own health instead of having the physician do the screening and doing the assessment and management. And if the female come in and they already know what they want to do and they ask their physician to do certain things, it might help them follow the recommendation instead.
Certainly. So from a public education perspective as well.
Yeah.
Sounds great. I'm going to jump a little bit because I want to make sure we have time to also talk to Heidi about her presentation and where she's going with her work. So Heidi, can you tell us a little bit about what your talk was about this morning?
Well, my talk was together with my colleague, my Belgium colleague, Inge Gerards, and we were talking about the implementation of the terminology for pelvic floor assessment. In 2021, Helena Froley and the whole group, they published a great article on pelvic floor muscle assessment. That was a part of it, and they did workshops and they made podcasts about it. But we were really curious whether it was implemented in daily use, but also in academia or in talking with the patient. So therefore, we did a very small, quick survey, not very methodologically sound, but to give us an idea. So that's how it all started.
Sounds great. And in terms of that standardization of terminology, why is that so important to us as professionals?
Well, there are a number of reasons, but I think one of the big ones is that we all speak the same language. And I think for academia as well, it's much better if we all use the same terminology if we want to do research and we use the same terms.
Absolutely. And I think, one of the things we talk about in research is that it often takes about 20 years for research to come off the shelf and get into clinical practice. So it's been about 3 years with this terminology document. What are you finding in terms of its uptake?
Well, of course, the people who responded to us, about 70% of those respondents said they were using it on a very regular basis, but there's still 30% who's not using it. And I think one of the problems is language, because I'm not a native English speaker, and there are a lot of not native speaking English people, so we have to translate the terminology. And my idea was, in the Netherlands we had a working group with all different experts, and we did a Dutch translation. Not a forward-backward translation, but we discussed the terminology in length, how we should translate it. And I hoped that other countries or with other languages would say, we need that as well. Then that we all use the same language. And I'm very happy. We asked the questions. Usually the room asked the questions to the presenter, but we asked the questions to the room. And people were really engaged, I think, and people came forward. Oh, we would like a Russian version, Portuguese, Spanish. So
Yes.
I think that would be a great, add-on for our profession. The only thing is I was presenting for physios, and this document is made by physios, and I think it's that important that also the physicians, so the urologists, the urogynes, the nurses, that they implement the terminology in the same way as we do. So I hope it will roll on.
Right. So it's translation in one sense in terms of language, which is very challenging because of all of the, some wording can be very specific in certain cultures. It's a lot of work to do a proper translation and back translation. But then it's also sharing and translating that knowledge across the different health professions to make sure that we're all speaking the same language.
Exactly.
And not, using terminology that we've kind of left behind. So
and not only in the ICS, but globally. And I just spoke to a colleague who was in the working group who made the document. And she said, she was in a country, she said, I heard hypertonicity, everybody was talking about it, still talking about it. So it wasn't adopted in that country yet. So there's still a lot of work to be done, I think.
There is much work to do.
It starts with bottom up, I think, that we all use it and try to do our best, and we hope to.
Is there new strategies to disseminate the information, like make it more digestible for a clinician who doesn't really have time to listen to an hour podcast or to listen to a report, like something really tangible, digestible?
I think a short form would be nice.
Yeah.
And for instance, in the Netherlands, we made webinars for our colleagues, so they could join in and watch the webinar and ask questions. But maybe that's too long as well. But maybe a short list with the most important terminology, that would already make a great difference.
Mm-hmm. And is it a plan to still assess implementation further on, or is just like that 3-year back?
We haven't got any plans yet. No.
Because 3 years, it's not a lot.
It's
right?
not a lot of time.
To look at implementation, knowing that it takes a lot of time for things to change.
But we wanted attention, so we don't want it to drop the attention. So maybe I have a feeling, I hope, that from now on the implementation will get another boost. And we continue.
And there are interesting ways to do that. One of the things you showed in your talk was the standard assessment form.
Yeah.
So that uses all the correct terminology. One of the things that clinicians face, of course, is that their assessments are through software databases where they're actually entering information online. So there's opportunities there to maybe have some of these forms programmed in some of those softwares.
Well, just imagine that we all use the same terminology, the same assessment form. You have big data.
Right.
Mm-hmm. So that would be great.
So it would advance practice in many ways, because then we can start also pulling those data to really answer important questions about effectiveness, symptoms, effectiveness.
Exactly.
Whatever,
you have to think big.
Absolutely. Sounds great. So thank you very much both for coming here and sharing your work with us here in the Live Lounge. And thank you all for joining us. And we hope to see you at more of these Live Lounge sessions in the future.
Thank you.
Thank you.